Now we shift to medications. We all prescribe a lot of medications. We love to do that. And this is something we need to pay attention to. There is no number to define polypharmacy, but suffice it to say it is excessive and redundant number in proportion to the illness that the patient suffers from. And you often see polypharmacy. You don't have to define a number. When you look at medications, follow some criteria. This is one criteria I would recommend called the Beers criteria. This is just a few pages updated every year by the American Geriatric Society. If you know the Beers criteria, you're going to be a super prescriber, and consider deep prescribing, which I will address. So these are some examples of drugs that we do use in excess. We use anticholinergics whenever people have abdominal discomfort. We use far too many antibiotics. There was an article in the Annals of Internal Medicine just 2 months ago on the fact that we have this habit of prescribing 10-day courses of antibiotics, even to minor respiratory infections. We often, and in that article, they chose 5 illnesses, and they said most of them you need only 5 to 6 days. We use far too many PPIs, which I'm going to address. Laxatives. As soon as the patient says constipation, we tend to use a laxative rather than determine a cause. We use excessive use of NSAIDs, sleeping pills, vitamins. And so these are just a few examples. If you use too many drugs, they interact with each other, with other nutrients, which causes a new problem or disease processes. And this is what causes adverse drug events. So for example, if you use phenytoin, and phenytoin might be appropriate, don't get me wrong, you need to be aware that through a liver metabolic process, they decrease vitamin D levels. So rather than just not be aware of this, those patients might need vitamin D. Warfarin, when you use green leafies, the dietitians or nutritionists often tell the patient, don't take green leafies. That should not be the answer. Levodopa, don't take food protein. You have to require food protein. So what would you tell the patient? Use green leafies, but use them in a controlled manner and a regular manner rather than binges of any item, including green leafies, a lot of them on one given single day and none for the rest of the week. So if you use some green leafies, you're providing some vitamin K, you will adjust the dose of warfarin. Levodopa, carbidopa is taken best on an empty stomach with water. So that can, you don't tell the patient not to take food protein. That would be a horrible advice. Grapefruit is different in that half of America takes grapefruit. So we need to be aware. I tell patients, I had one patient who came 1 month, actually before she died. I only knew she died later. 1 month with a terminal illness, and she asked, can I please take grapefruit juice? I said, how much would you like to have? She said, just a glass. I said, as long as it's a glass and you want to take a glass every day, that's fine. As long as you don't go with a large container. She was on a lot of medications which would be affected. She was so happy. 1 month later, she died. And I was so happy that, not because she died, that I did not say no to her. And oftentimes people say, don't take grapefruit juice. That's not some. Actually, they make these drugs more effective, statins and calcium channel blockers. So now question number 2, PPIs are commonly used inappropriately on a chronic basis for vague upper gastrointestinal complaints. A patient of yours is on PPIs for dyspepsia for over a year. That's what patients tell you, that I'm actually having dyspepsia or these discomforts upper abdomen. All of the following have been associated with the chronic use of PPIs, except which one? The consequence. Do they get a deficiency of B12 or folic acid? Do they have more fractures, or do they develop iron deficiency? This is chronic use of proton pump inhibitors. And the answer is all of them occur. This is only a fraction of what they may get, except folic acid. So you need to be aware that a lot of consequences follow the chronic use. The literature even talks about cognition, and I'm not going to say that that happens. This is the story of kidney disease and deterioration of kidney function, which you would not want to have from the unnecessary use of PPI. So what should you do? I will come to that in a few minutes, but question number 3, also referring to PPIs, the patient has gait abnormalities, 85 years old, from lumbar stenosis, is hypothyroid, already has CKD, and a history of falls. She takes combinations of ibuprofen. Now she's taking an NSAID, tramadol and lidocaine patch for pain, and uses omeprazole, obviously for the ibuprofen side effects, of 40 milligrams daily for over a year. The hemoglobin is 10, so she's already anemic and she has iron deficiency. She does not want an endoscopy. So she comes to you and she does not want an endoscopy. Your approach to the use of PPIs in this patient includes all of the following except which one? Do you want to continue PPIs because she's on ibuprofen? Do you want to advise tapering the PPI and stopping the NSAID? Do you want to suggest intermittent use of PPI as a trial? Do you want to educate regarding adverse drug events of PPIs and a tapering plan? Now, you must understand one of the formal indications, if you look at the guidelines, is that if you are on ibuprofen, you are justified by using a PPI, but how long should this continue? So this is where we have coined this term called deprescribing. This is in vogue now for about 6 to 8 years. It was more utilized in other countries such as Canada, but America is catching up. And we did a project where we showed that it is possible to deprescribe medications. And so if you are encountering a patient, you verify why this PPI is being used. Is it being prescribed by the doctor when you have control, or is it over the counter? Is it beneficial? Is it consistent with the guidelines? In her case, it is consistent with the fact that NSAIDs demand the use of PPIs, or is it unnecessary and can it be discontinued? If it can be discontinued, great. If it cannot, can the dose be reduced? You have two options. If either answer is no, then deprescribing is unsuccessful. But if it's possible to do either, discontinue or lower the dose, you follow up. You don't just do it, but you follow up for complaints post deprescribing. If none occur, you are successful. And if complaints occur, you reinstitute the drug. So this is an algorithm which we developed to deprescribe any drug, and I've used PPIs as an example. The Canadian guidelines tell you that you should not maintain, this is the Choosing Wisely guideline, incidentally, don't maintain long-term PPI therapy for GI symptoms without an attempt to stop or reduce the PPI at least once per year in most patients. Exemption, GI bleeding and Barrett's esophagitis. So these are two obvious. I would add Zollinger-Ellison syndrome. So there are some examples which are exceptions. So you should make an attempt. You don't succeed all the time. And so the answer here is not to tell her, continue the PPIs, but you really would try one of the others. You would try to stop the NSAID and thereby taper the PPI. Or if she's still hung up on the PPI, can you use it intermittently? Can you use it 3 days a week, which by the way, a lot of patients agree to. Can you do it for a month and stop it and see what happens? And then if you want, use it for a week or two. Then the patients are amenable. You have to show the patients that you care and that you're willing to try an alternate plan. And if you succeed, this is just one example where you can succeed in deprescribing, but there's a whole list of drugs you can deprescribe. And we found that 25% of the medications that patients use could be deprescribed over the course of 6 months in the study that we did. So deprescribing is here to stay. We all should attempt it. In every field, there are unnecessary drugs that we give to the patient.